Battery packs.
It's 5 o'clock. I'd like to call the meeting to order of the Health and Human Services Board on January 17th here in room 1284 of the Government Center. Roll call.
Dr. Anwar?
He's excused.
Julie Smith?
Present.
Lisa Lynn?
Present.
Sean Anderson?
He's excused.
Kathy Leaf?
Present.
Dave Osnes? Greg Telejohn?
Present.
Mike Barkalow?
Present.
Deb Lindeman?
Present.
We do have a quorum. I'd like to make an announcement. We will be pulling ordinance creating Chapter 41 from the agenda. Backstory to that is Supervisor Barkalow had requested it to be put on the agenda, and on Monday I have received an email from him asking it to come off the agenda. So we will not be addressing item 3 on the agenda tonight. Next is approval of the minutes from December 20th. Any corrections or additions or?
Nope, I'll move we approve.
If I don't have any corrections or objections to it, it will stand approved as presented. Public comment. We have a number of people here. We'll take public comment. We'll have a time limit of 2 minutes. I've got several names here. Matthew Rust is up first.
Thank you for the opportunity. My name is Matthew Rust. Earlier this week, I sent a letter to most of you on the board. I think everybody has received it. And it's about the agenda item that just got removed. But the point of it was basically just to remind everybody in public service that we're a constitutional republic, and we have constitutions, the federal and state constitutions, that are the supreme law of the land, and they cannot be violated by anyone in the legislature or anyone who has been given the authority to create statutes or laws or ordinances. Regardless if a neighboring county or if a different person or a different entity, government entity, has done something that violates the Constitution, it doesn't give anyone else the authority to do that. And in this case, we have a constitutional guaranteed right to assemble. And this ordinance was attempting to give a government official the fictitious authority to take that away from us and to prohibit public gathering. That's a blatant violation of the United States Constitution and the Wisconsin Constitution. And anybody voting in favor of that or to try to get it passed into an ordinance now or in the future is violating the Constitution. And you took an oath to the Constitution, not to a supervisor, not to the state legislature. But thank you for the time. Just want to remind you of all that for the future. Thanks.
Hello, Sarah Bachland. I live in Troy Township. I didn't really have anything prepared today. I knew that this was going to be pulled from the agenda because I spoke with Supervisor Telejohn earlier. My question is, and I know that you won't answer here, but why it couldn't have been pulled from the agenda ahead of time? I don't know if there's any significant meaning behind that or not. perhaps if it gets pulled, maybe you can bring it back up, the same resolution up again. I don't know. I hope not. I echo everything that Matthew Russ stated, and I don't think anyone needs to be reminded of 2 years ago how this all happened. So, thank you.
I think I'm with that.
Sorry. Sarah Gall?
Thank you for the opportunity to speak tonight on this, the same issue. A couple years ago, I was not living in this county, but I felt really compelled to join with people and friends that were here to just to encourage my people here. The ordinance that was proposed was just so unconstitutional. It was unfathomable to me. And now my husband and I and our family live over here in St. Croix County. And so now I'm just speaking on this because it's unfathomable to me that you would, more authority would be given than what the Health and Human Services Director than what is in the statute. Statute 252 needs to be gutted, and that's a legislative issue. We can all appeal to them for that. It's my understanding that the county association, the county associations, they gather together, and I happen to know that at one of those meetings, this was a topic for discussion to give more authority to the Health and Human Services Director. And so I just think that it's upside down and backwards and violates the spirit of our Constitution and the way we operate in a constitutional republic. And so I just wanted to make those points, and thank you very much for your time.
That's all I have for names here, but is there anybody else who'd like to speak for public comment? Anybody else for public comment? Hearing none, one more time, public comment. Thank you all.
That's why I'm here.
Yeah, thank you. We'll do Health and Human Services monthly financials.
Good evening. So the financials through December of 2023 are included in your packet. We had quite a few revenues come in during the month of December. Last month in November, we had 22.68% remaining. We're now down to 6.71%, so a fairly substantial amount came in. A lot of that was our WMCR money, which is the Wisconsin Medicaid Cost Report Settlement, which was our CCS dollars and our other Medicaid funding from the other programs we have. As a reminder, we will continue to receive collections for our services for January. Will get posted back to December of 2023, and state revenues for our 2023 contracts will be posted back to 2023 through the end of when we receive all of them. So sometimes that's all the way into May of 24. For expenses, we will have a full payroll from January, and half of the second payroll in January will be posted back to 2023. So we'll continue to see salary and fringe and some operating expenses still showing up as 2023. But when you look at the number on page 9, last month we were $3 million in the red. Now we're at 1,699. That will go down a little bit, but we will still likely end the year at a negative balance. If we go all the way to the health center campus, and that is on page 24 of the packet. December revenues for the healthcare campus did not make it into the report. That amount was $690,377. once that amount is in there, the healthcare campus as a whole has a positive balance of $217,000. They will not have any additional revenue or very little revenue that would get posted. Their revenue is calculated during the month of December and then posted in December. They will have additional expenses, same as human services with the payroll and some operating expenses that will go back to 2023. But for the most part, we expect them to end the balance at a positive amount. Depreciation, I think, again, I mentioned that last month was added in here, so for the most part, everything's included that needs to be. Any questions for me on the financials?
May.
Go ahead.
So in the healthcare campus, there's a building depreciation, am I reading that right? 524,000 in the negative. What, roughly what is that?
We don't budget for depreciation.
Oh, okay.
So that's why it shows as a negative, because it's not against a budgeted amount.
Yeah, it's not just
But
a
it's
loss.
the amount that, yep, would get posted if you look at the prior years.
Okay. So it's not necessarily a dollar amount, it's just a depreciated asset.
Yep.
Okay.
The reason we don't budget for it, even though we know it's going to occur every year, is because we try to budget on a cash flow basis. So depreciation is a book entry. There's no money actually moving anywhere. It's just, keeping accountants employed. So when we create the budget, we try to do it at cash flow so we can see whether it's going to have positive or negative cash flows, because that's really the decision-making for the county board of whether they continue that operation, as if it's fiscally prudent to do so. And so the non-cash items, depreciation, and there's also a WRS adjustment that's made every year. We don't budget for those items, but that's why.
Any other questions? Thank you.
Okay.
Next is public health orientation. I believe Ellie is going to present that.
Thank you, Mr. Chair.
Here, use this one.
Test? No? All right. Let me start. Thank you.
Can you just say all that again?
Yes. Yeah. That one's working. All right. Whoa. Yeah, so Ellie and I talked about providing a presentation to the board as a part of orientation as the health board to the topic of public health. What we wanted to do, and again, just so it's on the record, I gave Ellie a rough draft of a presentation, and then she made it look like it does now. But the idea behind this was to, in reflecting on the pandemic especially, we realized that a lot of people in our county and around the nation really didn't have much exposure to public health prior to the pandemic. So that was their first introduction to what does public health do, how does it do it, why does it do it, et cetera. So as a part of our board orientation, we always look at what we do as a county, what our public health structure is, what the statutes are in the state that we have to abide by, et cetera. But what I wanted to do was step back from that a little bit and provide just a brief historical glimpse at why public health developed in the first place and under what conditions and circumstances. So we're trying this out on you to see if it's helpful, first of all. And if it is, then we'll add it to a broader sort of orientation for either this health board or future health boards and the Board of Supervisors if they're interested in learning more about this. I have a public health degree, so I was fascinated by all of this history. Probably you're not as fascinated, but what I wanted to do was just sort of look back in time a little bit and say, during the Industrial Revolution and around that time, what were the circumstances that led to the development of public health, and then how did it evolve? So I'm going to turn it over to Ellie because she can explain the slides more concisely, and you'll be here less time if she does that. And then I'll chime in if I have comments, so if that's okay.
Thank you, Bob.
Yep.
And thank you for your attention tonight. So as Bob stated, this is kind of the brief history of public health. But to orient you first off, what is health and how are we defining it? So health is a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. And then moving from health into public health. So public health is then the science and art of preventing disease, promoting life, promoting health through the organized efforts, informed choices of society, organizations, public, private communities, and individuals. So as we can see, these are both the WHO, the World Health Organization, and the CDC. These are very standard definitions we use to define public health and health. So public health really developed from kind of a need to protect citizens from health threats. So, when you think about Europe in the 18th century, we've talked about epidemics, these densely populated areas. So all of a sudden there was alerts that we need to protect people. These health threats are spreading. So that then became a public responsibility, which then became shaped by the scientific understanding of the cause and the spread of disease, and then the means to control disease. So really that formula is still kind of what exists for our modern public health system. And so this is kind of just a very brief outline of development of public health in the United States. So public health really started in the 16th century. So 18th century. 1701, Massachusetts actually passed laws for the isolation of smallpox patients, and then they would quarantine ships that came into port. So the first kind of control of disease by a governing entity had started. As we move into then the yellow fever epidemic in Philadelphia, that actually prompted Philadelphia to create its first Board of Health. As we move into the mid-1800s, later 1800s, reports were coming out about sanitary conditions in kind of the Industrial Revolution periods in these high population crowded areas where disease was spreading, especially in New York City and other areas, so that by the 1950s there were actually 40 states and local areas that had established health departments. And then by the end of the 19th century, the big piece here is now people were starting to understand disease and the control of disease. There was germ theory, we had bacteriology, people knew that bacteria spread respiratory diseases and how they spread and how to control them. So this is kind of public health's evolution. So we had the environmental and sanitary conditions, we had crowding, we had how disease spread, and now we have laboratory science and some real background of how to prevent and control disease, along with epidemiology. So I'm going to give you a couple examples that really illustrate this point. The first one is the influenza pandemic of 1918, the Spanish flu. This is kind of the first and worst scenario, and we're talking about epidemics in mass society. Due to how many people fell ill, how many people influenza is approximated to have killed, we can see the death toll there was incredibly high. And unfortunately at this point, vaccines had not been discovered, so there was no vaccination. So public health was implemented, and public health nurses became organized. They did a community-wide response. They're kind of those established things all the way back to Massachusetts in 1701. Again, isolation was used. That's how we quarantine, disinfection, and personal hygiene, just the basic washing hands. Public health was their education process. So again, a lot of these basic principles of minimizing respiratory infections that we still use today in public health. The next one that I don't want to age anyone. Some people may remember, but is polio. So polio and polio eradication was a huge public health effort. Polio outbreaks, there was a lot of public fear. Pools were closed, schools were closed. People really didn't know. And so public health was really mobilized as that education to calm people, to help people understand how this disease was actually transmitted, and then to teach families how to care for their children who actually were afflicted with polio. There was now vaccination technology, so there was a licensed vaccine. It moved forward. It was implemented and distributed, and so we have had no case of polio since 1979. Unfortunately, you can't really read the fast forward. I don't know if we can scroll down. Unfortunately, in 2020, you can kind of see it. There we go. In 2022, we have had now the first case of paralytic polio in the United States in decades. So, but major advances. The last example is public health and the eradication, or excuse me, the elimination, not eradication, the elimination of measles. So one big piece of that helps public health kind of understand the spread of disease and the impact on the community is the reporting of this disease. So those cases then became a public health reporting system. So public health really knew how many children were being impacted, where to target those interventions, because they were experiencing about 500 deaths a year in the US and 48,000 hospitalizations a year. So there was an identified need for control. They did isolate it. A vaccine was developed, which is another public health intervention again. And then once we got that widespread vaccination, they actually used that science to realize a second dose by 1989 was recommended in schools as this epidemiologist, this surveillance had happened, and it became 97% effective. Therefore, measles was eliminated in 2000. So through public health efforts of vaccination, through vaccination rollout, and through the science of vaccination, public health to this day continues to provide measles, mumps, and rubella to children for school readiness. If you fast forward, unfortunately, there are pockets. We have a lot of international travel. We have pockets of unvaccinated, and therefore, in 2002, we did have 101 cases of measles reported in the US. And just this past year, there was a confirmed case of measles in Wisconsin. The worry is, as you can see previously, that measles causes complications in about 3 out of 10 who are infected. So it is a nasty, nasty disease. So now that we've kind of understood what has shaped public health and kind of major pieces, I can focus more on...
Sorry, Smouse is not being happy tonight.
It's all right. There we go. That's perfect. So what you're seeing here is actually the development of public health in St. Croix County. So public health has, we know back in the 1800s, Wisconsin became a state. Well, under 30 years from that, the State Board of Health was formed. So then, and actually in 1913, the first state health officer position was created. As we talked about when that was in relation to Spanish flu, then in 1929, county health departments, like this here in St. Croix County, were authorized. And in 1936, St. Croix County hires their first public health nurse for tuberculosis. So St. Croix County has had a long history in preventing community-wide diseases and working for prevention for the county. You can see kind of in the late 1800s, as public health started to grow, we had WIC, social services, and we kind of merged into this. Finally, in 1994, the St. Croix County Department of Health and Human Services was established, as it is today. So,
I'm sorry.
it's all right. It's all right. I'll just go ahead and say, just kind of as we bring it to a close and kind of what the main message is and why public health exists is because we really work for the public. So a doctor treats one illness, one patient at a time. And public health really looks at all of these trends of diseases. They really look at all of that illness, whether it is morbidity, whether it is mortality, and in the entire community for prevention programs, for disease surveillance, kind of adapting and expanding and ceasing work dependent on really what we're seeing in the community. So we do work for the entire community. And then just in summary.
I'm so sorry.
Yeah, it's all right. Here it is. In summary, this is kind of what I thought was a great synopsis of public health. So public health, I'm just going to read them off for you, is a workforce bound by common aspirations, based on principles of social justice, addressing a constantly expanding agenda of problems linked with government, grounded in science, and emphasizing preventative strategies. So, thank you for your attention tonight.
I find it fascinating to look back in time and see how, as population centers began to grow around port cities especially, and population density really increased in those areas, how disease spread, waterborne illness, environmental kinds of threats, all of those things really led to governments recognizing that there needs to be some sort of infrastructure here in order to prevent these illnesses, these deaths, and these kinds of environmental hazards that were resulting from the dense populations in these in the 17th and 18th, or 18th and 19th centuries. So as it evolved, you know, as Ellie so nicely stated, as public health evolved through the years, the technology and the expansion of public health occurred. What we're looking at here in St. Croix County now is really how do we use those population level data, how do we use the understanding of disease and the way it works within populations to guide our intervention strategies in other areas of HHS? How do we design effective, targeted kinds of interventions in behavioral health within the ADRC, people with disabilities and seniors, and children and families? How do we design intervention strategies looking at population health data that helps to guide those strategies? So it's really a nice merger. Even though public health's been within Health and Human Services for years now, it's a nice merger between the population health aspect of public health merging with the intervention side of human services. Data-driven care, as we all hear about. So Ellie has been very helpful in her time with us at St. Croix County in the past three plus years in helping us make that bridge between population health prevention strategies and intervention strategies as a part of program development. So I hope that makes sense. But the idea here tonight was to introduce this as a part of a future orientation for board members, just to help, and the public, just to help put in perspective why public health developed really out of necessity for the workforce at the time, and to prevent lost productivity and to prevent death and morbidity or mortality. So anyway, that was the idea. So I'll get your feedback and we'll take it from there as far as what you thought about this kind of presentation. Thank you, Ellie.
I thought one interesting aspect when I saw a webinar last week was just preventing foodborne illnesses at restaurants and so forth. People don't think that's what public health does also. They're monitoring restaurants, and when there's an outbreak of food poisoning, they're the ones that track it down and try to find out where it's coming from. So besides any other diseases or so forth. Any other questions or comments or? No? Okay. Thank you, Ellie. Next item is behavioral health updates.
Char Lopez will be doing this.
Good afternoon, Char Lopez, Behavioral Health Administrator and Health and Human Services Deputy Director. We've actually had some exciting things happening in behavioral health, and one of the most exciting things is we have a supervisor, and we're going to keep this one. Stephanie Grier. She is overseeing anything crisis, adult protection, the co-responders, our community case managers. So she's been with us in that position for maybe about 3 months, 2-3 months. We have a couple of funding opportunities that we had through some grants that to hit those areas that we have struggled with. So housing is the one thing that we really, really struggle with. And we've been able to utilize some of our state opioid response grant funds and ARPA funds to pay for a month's rent at Sober Living. So we have had a longstanding contract with Onyx, and we have had a tremendous response to that state opioid one in particular. So that is actually very exciting. We have a mental health supplemental grant that we have monies available for rent. So if we have a client who is service connected, has a serious mental illness, and is in some sort of transition, they're coming out of jail, coming out of the hospital, coming out of group home, and needing some help to get stabilized, we were able to use this grant funding to provide up to 3 months rent, which is big when you're in transition. So that funding is only available through March of the 14th. That's March 14th of 24, I'm sorry. And that supplemental block grant, that is the last time they're telling us that we're going to get that one. So that one's done, it's done. Also, we're able to use our state opioid response grant to do a process evaluation for the behavioral health process for the integrated clinic. So everything from the very first phone call that somebody gets to their last discharge meeting. And we actually had one today. Bob was able to, and actually Faye was able to be part of it, to just kind of hear the process. And it was a little overwhelming. I don't know what you guys thought, but I was like, wow, it's really, sometimes it gets really complicated. And to be a client to have to go through that, we really want to streamline it and make it as efficient as possible. Waukesha County had done this, and they were actually able to hire 2.5 more staff because they were able to make their process so much more efficient. So we're really hopeful that we'll have a really good product in the end. One of the things we continue to struggle with is getting substance use counselors. We had just made an offer to a very qualified candidate who turned us down. It's a position that's been open for over a year, and it's a struggle. We continue to look. We now have a staff who can supervise and in training licensed staff, so that will hopefully open the door for some more applicants. Adult protection this year, I think Heather Amos can probably attest to this too. It has been just record year with not only the numbers that we've had, but the complexity. We've had probably a great increase in clients that maybe have a long history of mental illness, but also have dementia, and they're very, very difficult to find services for, and it is an increasing population that we really struggle to find the appropriate services for. We just looking at numbers, in 2019 we went from 400, and we have had a steep incline last year. At the end of 2023, we had logged 583 services. The one that has been the greatest increase, as you can see, is that financial exploitation. Again, if you ask Heather, I'm sure that she would, it's every day there's a new financial exploitation that comes in. And then just on a final note, we continue to provide our outpatient services with both substance use and co-occurring disorders. Our wait lists, we still have wait lists for our mental health. It's still about 2 months out, which is about par with everywhere else. And our substance use, we have had to put a hold on taking new clients. So we do assessments, and we've been able to refer out to other facilities that do have openings in the area. We do continue to prioritize clients that either have adult protection connections, if they're IV drug users, if pregnant, and which sometimes creates even more of a wait list. But we want to assure that we're addressing the high need priority clients. We continue to work with Justice Support, the jail, the Sheriff's Office, and other law enforcement to build innovative interventions and strategies focused on the intersect of the public health and public protection, public safety. And then we've recently hired a behavioral health nurse, actually today, as recent as today. So our last behavioral health nurse was lured back to her last place of employment. So she was an amazing nurse, and she will continue to provide services for us because she's working for another facility, just in a different area. So we have the MAT program currently is on hold in the jail just because she just started today. And we do have we have an LTE who's filling in, doing the injections for clients that need them, the court-ordered, either court-ordered or voluntary injections. And we have, on any given week, probably about 11 that we give, which we have her, I think, for 15 hours a week. So it really almost takes up almost her entire schedule right now. So as soon as that staff becomes trained, we will start the MAT program up. It was actually kind of an okay time because there is a couple clients that were receiving MAT who just left the jail, and there hadn't been any that were just starting. So if we probably within the next month, 3 months, we'll be able to get her up and running. Yes.
Can you explain what MAT is and what the grant is? I
Sure.
know, but I don't think others do.
Sure, absolutely. So it's the medicated-assisted treatment that we have within the jail. So if someone in the jail, I should back up a little bit. So part of the programming that Kathy Borgschatz did when she came back to the county is she facilitated a COSIP grant that allowed her piece was to really set up the programming and to really get that the ball rolling. And so in that, the jail nurse initially started doing it. So when somebody was looking to start on a medicated assisted treatment that would assist with their recovery when they're leaving jail, they could do that while they're in jail, and then they would be able to give them an injection that would be a 30-day, it would last about 30 days, and then with the hopes that we could get them connected to other services. So the jail services quickly found that they were overwhelmed with other things because they continue to have difficulty getting enough jail nursing help. So then we had teamed with them. So our jail nurse and our psychiatrist teamed with the jail. Our psychiatrist has his appointments via telehealth. The jail nurse shows up, does the blood draws, does all of the medical, and then after screening and education and that determine that that's a good fit for that client, then they can give them the medication that will assist with that recovery, that longer term recovery as they go out the door. The bonus to that is then those who are working with our psychiatrist and our nurse can then just continue their services with our psychiatrist and their nurse. They're given priority when they come through so they can continue their medicated assisted treatment. So,
Could I just add one thing?
Absolutely.
So the medication that people receive with their consent is Vivitrol. It's an injection of naltrexone. Naltrexone, yeah. And that, like Shar said, lasts about 30 days. It helps reduce craving, and it can help reduce the effects of the drug if they do use it in some people. And it works typically in people with alcohol use disorder or opioid use disorder. But it's an injection of naltrexone. It's a pill that you can take daily. This is an injection that lasts 30 days and can help with craving for a longer period of time where they don't have to rely on taking a pill every day.
and we've been able to supplement that with our SOAR grant, our state opioid response grant as well, because that medication is very expensive. So we've been able to purchase that injection, so when they come out, they have that available. A lot of times, just because they may not have medical assistance or another private insurance, so to assure that they have the ability to continue that if they wish to do that. So.
Any other questions? No? Thank you very much.
Thank you. Thanks.
Request for future agenda items. Is everybody silent? Good. We won't have another meeting. Announcements or correspondence. I'd like to publicly recognize Dr. Anwar for serving on our committee. Wasn't able to be here tonight, so he can't. Hopefully, he's listening in or something. But I want to publicly recognize him for his input and service to the committee, and thank him very much for his time. Any other?
Yeah, he's moved out of the district, so this would have been his last meeting tonight.
Yeah. So hopefully we'll have somebody replacing him soon. So any other announcements or correspondence? Go ahead.
Thank you, Mr. Chair, and I too want to extend my thank you to Dr. Anwar. I do have an announcement. Kelly Ingen has moved on from St. Croix County, and I wanted to say just a little bit about her contribution to the Public Health Department here as the Health Officer and Public Health Division Administrator for over 5 years. Kelly, especially during the pandemic, was under a tremendous amount of stress. Her and the whole division were to respond to this pandemic, as most of that responsibility fell on local health departments. And she worked long hours just for the purpose of trying to protect the health and well-being of St. Croix County residents. And we're going to miss her, and we wish her very well in the future. But I have on the heels of that, I have another announcement that I'd like to let you know, if you're not aware already, that Ellie Clausen, who did such a nice job with this presentation, our epidemiologist for the last 3 years, has accepted the position of interim health officer and public health division administrator. Ellie has a very interesting resume. If you look at it, she's got a Master of Science degree in public health from Johns Hopkins University. She's worked in India, Peru, Kenya, where else, Ellie? Nepal? And I think you told me once that you actually made it to base camp on Mount Everest, right? You did, yeah. So she's got that going for her. And Ellie, I think, has shown her skill and her knowledge base in many board meetings during the pandemic and since, certainly today. And I know that she's the right leader at this point to take our public health division to the next level as we look for a permanent health officer and public health division administrator. We'll be recruiting, we're going to recruit soon for that position, but during the interim, very pleased to announce that Ellie will be stepping into that role. Congratulations.
Any other comments, correspondence? No? Date of the next meeting is February 21st at 5 p.m. unless we don't have any agenda items. Well, Ken will make some up, I'm sure. Meeting is adjourned.